So, just to remind us that asthma isn't a new disease. In 1698, Sir John Floyer wrote, "The preface to the treatise of asthma. Since the cure of asthma is observed by all physicians who have accepted an eradicating of that chronical distemper to be very difficult and frequently unsuccessful, I may thence infer that either the true nature of that disease is not thoroughly understood by them, or they have not found out the medicines by which the cure may be effected." As I read that, I'm reminded that there is still so much we don't fully understand about this term asthma, and we have still got a lot of work to be done. Joseph Carrere devised his first inhaler in 1847. It's certainly a bit different to our modern-day puffers and dry powder devices. Heaven forbid, in 1882, Dr. Batty's asthma cigarettes were marketed for the temporary relief of paroxysms of asthma. Dr. Schiffman's Asthmador cigarettes to relieve the distress of bronchial asthmatic paroxysms. Contains no tobacco. I often wonder what on earth was in those cigarettes. Well, our guidelines certainly are a global experience, and I think one thing we need to remember that when we're developing guidelines, it certainly needs to be very specific to the country for which those guidelines are going to be implemented. They need to be health system specific, and tailored to the people, the health professionals who are going to be implementing them, doctors, and also for our patients. They need to reflect local conditions, culturally and affordability. There are certainly good national and international guidelines to consider. I think one of the main ones that the Australian guidelines relate to is the GINA, the Global Initiative for Asthma. This is the international guidelines. There are also many guidelines that help us in developing guidelines as far as the methodological overview and also implementation. The Australian Asthma Guidelines were one of the first Australian treatment guidelines for asthma in 1989. And this was in response to the increasing burden of disease. And how lucky we are now that that death rate is about 400. It seems the last few years of statistics hovers around 400. But it was nearly 1,000 in 1989, which is quite frightening when we know that most deaths are preventable. So there has been a good job done. There was a quick realisation that general practitioners and general practice in general was where patients went to have their asthma treated. So the guidelines are targeting those groups, so they're primary healthcare professionals. It was also important, if that's where the target was for these guidelines, that GPs are included as co-authors, and on all working groups, GPs are well represented. Then, of course, we need to distribute those guidelines to where it's going to be used, and that was to all general practices, including general practitioners and practice nurses. There needs to be some education program to ensure that those guidelines are implemented. So the 2013 edition, which is the 7th edition, is nearing completion. I was hoping that we could have launched this, had it launched by now. We were aiming to have it launched in May, but it is a massive, massive job. And because it's been such a big overhaul of the previous guidelines, it probably will be released later this year. The multidisciplinary guidelines committee and 2 topic working groups. So for each topic, there's a separate group. And this is about 80%, 80 people have been involved in those, the development. The guidelines methodology was adapted for Australian needs and capabilities. So just to give you some idea, there was the 2002, I couldn't find pictures for the really old ones, which was sad. The 2006 guidelines are the ones that you may be familiar with, and as you can see, 2006, so definitely time for an update. We're not sure what the new one will look like. So to just give you a bit of an idea about the methodology that's covered, for phase 1 review of currency and relevance, each topic subsection in the 2006 edition, a GP reviewed the content, advised on its relevance, and identified other areas of practice on which guidance is needed. These reviews informed the Guidelines Committee when devising the clinical questions. A specialist clinical expert advised on the currency of information and recommendations and provided selected additional evidence. These reviews were provided on to the topic working groups as background information. So when we looked at phase 2, the Guidelines Committee agreed on a comprehensive list of clinical questions informed by the GP and specialist reviews. For each topic, a working group reviewed and amended the clinical questions. The agreed list of clinical questions formed the scope of those guidelines. Phase 3, the committee selected 6 clinical questions for systematic review. These fulfilled the following criteria. How was it relevant to primary care? How was it likely to influence practice? And was it likely to improve patient outcomes? Phase 4, a research assistant undertook systematic reviews in consultation with a clinical expert consultant. The findings were reported as evidence tables, structured into subsections according to subpopulations, for example into children and adults, and also the type of intervention. The topic working group assessed the evidence reports and drafted evidence summary statements, both overall and for each identified subgroup or type of intervention. This was then drafted as a recommendation and discussed until consensus was reached. The final recommendations will be graded using the NH and MRC grading system. Phase 5, to draft the supporting text, including an explanatory method and or notes for each recommendation. So evidence-based recommendation indicates the grade of evidence based on systematic literature review. For each recommendation of this type, the mini appendix will list all evidence that met inclusion criteria for that question. Recommend based on a limited, non-systematic literature review. For each of these recommendations, the mini appendix will list all relevant evidence considered. Recommendation based on selected reliable source. For each recommendation of this type, the mini appendix will list sources that had major influence on that recommendation, indicating the type of source, for example, whether it's a review, a systematic review, or a clinical practice guideline. Consensus recommendations were based on expert opinion and experience. So to make the guidelines relevant, we needed to ensure that the focus remained on what was the evidence-based practical tips for general practice. So how was this going to be useful, and how was it going to, and it was going to be very practical information. Prior to the development, there was a survey conducted by those using the guidelines, and this was evaluated and reviewed before this revision began. The guidelines will present the research in a usable format, and so there will be summary practice points with notations of which research was used, and there will be every single research or piece of evidence that has been used will be listed. Greater recognition of lifestyle risk factors, for example, smoking exposure, both active and passive, ideal body weight, regular exercise, reduction of trigger exposure, the role of obesity and weight loss in asthma control. We know that even losing 5 to 10% if overweight can have a clinically significant impact. Consideration of exercise-induced bronchoconstriction without asthma. This is quite a new thought. Protocols for managing acute asthma from community through to the hospital setting are being reviewed. There's a new Cochrane review published last December. Diagnostic algorithms for children and adults will be available as infographic features on the National Asthma Council website. There will be practical advice on spirometry, including recommendation to refer if untrained staff or equipment isn't available at general practice. The approach to management of asthma in adults will be more in line with international recommendations, not basing initial treatment on theoretical assessment of underlying disease severity, but more on current control. This approach is aiming to distinguish between the severity of an attack versus overall control. Having trouble here. So where to now? There will be a new name. It will be called the Australian Asthma Handbook. There's a few jokes going around the office, aha. New format, 2013 main format will be a state-of-the-art dedicated website. There will still be a print version available, but this will be smaller and more a pocket book of just the key messages, including those practical tips and practice points. So how do we implement these guidelines in a national way? We will have a significant national media launch, hopefully with the Minister for Health. Dedicated national distribution over a period of 3 years. So that will be word of mouth via our website and people contacting the National Asthma Council to have them posted out. Our pharmaceutical colleagues often help us distribute these as they visit general practices. We'll have it through the Australian Practice Nurses Association also. Since 2001, there has been an education program conducted by the National Asthma Council. It's called the GP and Allied Health Professional Asthma and Respiratory Education Program. We're very grateful to the Department of Health and Ageing for funding this program. We've just received notification that this funding now will continue for another 3 years from July. We're very grateful. So this program targets primary care, so GPs, practice nurses, allied health professionals, including Aboriginal health workers and Indigenous health workers. And it's also that we really target rural and remote areas as well, and over 50% of our workshops are conducted in those areas. We have specialised topical information papers based on those 6 clinical questions, and these are tools for primary care. The presentations at conferences such as this, we will certainly continue to use medical and general media opportunities. On your table you'll see one of those information papers. This is the Asthma and Healthy Living. It will be released next week, so you're very privy to that. All of our information papers have a health professional one in the larger size and a smaller one. Same information but just more consumer focused. So this is what we can give to our patients. After a long process, the National Translation Service provided guidance as to the languages that were most useful. Hence this patient brochure on asthma is available online in Arabic, Chinese, Korean, Vietnamese, Spanish and English. Also on the table you have an information sheet about the National Asthma Council, Australia, and information regarding the Health Professional Education Program. So with all that in mind, how is this relevant to primary care? With over 2.2 million Australians having asthma, it's a high priority. Asthma is one of the top presentations to general practice, and I was chatting to a respiratory physician colleague the other day and he was saying that he as an adult, hardly ever sees asthma. And again, that just highlights that most of the people that have asthma have care from their general practice. People are still dying from asthma, and that's tragic when we know that most are preventable, so we've still got a lot of work to do. There's certainly studies suggesting that there's inappropriate use of our asthma and respiratory medications, and that people who have asthma are not ideally controlled. We know that there can be improvements in both those areas. And that also makes it a huge cost to our healthcare budget. So how is this relevant to you as practice nurses? The role of practice nurses is highly important in the management of chronic disease, of which asthma is one. With the introduction many years ago of the chronic disease management plans, GP management plans, team care arrangements, the asthma cycle of care was introduced in 2001, changed in 2006. You are very well placed to pick up on things when you're doing those assessments. Health assessments, those age-specific health checks, when you're performing spirometry, disease-specific nurse-led clinics. For those of you who have a special interest in respiratory health and together with smoking cessation, look at doing some extra training. We have some wonderful organisations around Australia that provide that. Look at running some nurse-led clinics in general practice. So to find out about the Australian Handbook, you'll notice that the National Asthma Council website was changed, it was a new website just earlier this week. So you just go under the Health Professional tab and look for Asthma Management Handbook, or it'll, with the new name when it's released later this year. So the Australian Asthma Handbook, for information you can just either contact us either by web or by phone, www.nationalasthma.org.au. Thank you very much.